It is my privilege to introduce Satoru Ito, who is one of our fantastic pain specialists and a pharmacist in pain and palliative care. He agreed to open this talk up to our larger Grand Rounds community. So I, again, am just really thrilled that he and his colleagues are willing to share their knowledge of ketamine with us in this larger format. So again, thank you so much, Satoru. I really appreciate it. Mr. Ito graduated from the University of Arizona College of Pharmacy, and after completing his first year of pharmacy residency at the University of Chicago, stayed at the University of Chicago as a clinical pharmacist, and then decided to specialize in pain management. So he joined us here at the University of Washington to do the pain and palliative care residency this past July. So thank you again. And I'm going to turn it over to you to teach us about ketamine, because again, I think this is a really important up and coming emerging treatment and topic on the palliative care side as well. So thank you for sharing with us.
Thank you for that introduction. Sorry, I'm in a large room by myself, and probably my colleagues of palliative care people might coming into this room. So sorry if there's any distraction during the presentation. Again, my name is Satoru Ito, one of the clinical pharmacists, and join with me later during the question and answer portion will be Dr. Mackenzie Welsh. She's my colleague, pharmacist in pain palliative care, and as well. So look forward to that question and answer session. So like Dr. Hirano said, ketamine has been gaining a lot of popularity these days, and so the providers here at the UW had asked us to talk about it, teach the provider group about the medication, and see if we can implement that more in our palliative care setting. And I'll be discussing more of the IV ketamine infusion and specifically in the palliative care inpatient setting. With regards to this presentation, I have no actual potential conflict of interest, and I'll be talking off-label use of ketamine during this presentation. By the end of this presentation, I hope you'll be able to identify patients who may benefit from ketamine infusion in an inpatient palliative care setting, formulate a ketamine therapy monitoring regimen, and then finally to identify side effects from ketamine and their management. So I'll be discussing this presentation using a case. We'll go back to this case towards the end of the presentation as well. So let's say we have a 41-year-old woman with metastatic breast cancer, and she comes in with the severe left hip and thigh pain, and that they're from a tumor. And she also complains of lower back pain as well, and then you also know that is coming from a tumor. And she denies any past medical history, so not so remarkable. And she received multiple chemotherapy regimen and also palliative radiation to the left femoral head. And after all those treatments and radiation, she and her family decided to not pursue any further treatment, and goals of care discussion occurred, and they decided to be go into comfort care. However, during the hospitalization, the disease continued to progress and the pain became more increasingly uncontrolled. So let's say that this patient is currently receiving hydromorphone PCA, or patient-controlled anesthesia, with setting of incremental dose of 2 milligram, blackout interval 10 minutes, clinician bolus 3 milligram, and continuous infusion of 3 milligram per hour. The patient used 120 milligram of the IV hydromorphone through PCA over the last 24 hours. And she's also receiving dexamethasone 8 milligram daily for bone pain, as well as acetaminophen. We tried to rotate to different opioid regimen for PCA, and we tried fentanyl, and she got too sedated. so couldn't tolerate that. We tried methadone, but there was high concern for prolonged QTC, so I decided not to do it. Buprenorphine was tried, but it provided inadequate pain relief. And thinking about non-opioid regimen, pregabalin, duloxetine, and NSAIDs all provided inadequate relief. So we'll be talking about ketamine. Ketamine's been around for quite a while. It was first synthesized in the 1960s, approved by the FDA in 1970 for the use for general anesthesia. But over time, though, especially in the last couple of decades, the use of ketamine for the management of pain have increased, and palliative care is not an exception for that. So I want to briefly go over how ketamine works. It works on the NMDA receptor, or N-methyl D-aspartate receptor. It is typically located in the dorsal horn neuron. It is all over the body, but a majority of it is concentrated in that area. And it is often upregulated in patients going through chronic pain and also central sensitization. So continued pain insults coming through, glutamate, the excitatory neurons being released, and that binds to NMDA, and cascade of events happen and cause pain signals to conduct through the neurons. And it has a major role in chronic pain, also with the neuropathic pain. Opioid tolerance can happen because of NMDA, and allodynia, hyperalgesia can occur, and NMDA is really heavily involved in that. And NMDA is also shown to have some mood regulation property as well. And ketamine inhibits that NMDA receptor and blocks the cascade to occur for actual potential and pain signal to conduct through. But ketamine also has other mechanisms of action, not only the NMDA receptor. So I'm not going to talk in detail about these other mechanisms of action, but you can see that ketamine works in a variety of ways, and also side effects can occur because of all these variety of ways too. Now, ketamine, specifically IV ketamine, it is lipophilic and hydrophilic. So that means what that means is it extensively and rapidly distributes throughout the body, including crossing the blood-brain barrier as well. So that allows the IV ketamine to have a quicker onset of action, and it seems to be about 30 seconds, especially for anesthesia use. The data have shown 30 seconds onset of action. It is metabolized by the liver, and one of the metabolites is norketamine, which is active metabolite. So that can still provide some analgesic effect as well. Elimination half-life is about 2 to 3 hours, and it is excreted renally. Now, indications of IV ketamine. The FDA-approved indication is only just for general anesthesia, actually. But look at how many off-label uses out there, including agitation, and of course, we'll be talking about pain, depressive episode of depressive disorder, sedation, even for seizure as well. And there are a variety of formulations out there. And of course, we're talking about IV ketamine. It can be given IM or sub-Q as well. The one in the middle is intranasal formulation, and that's actually S-ketamine. It was approved fairly recently and used for depression, or treatment refractory depression, rather. The other two in the picture are topical ketamine and oral ketamine, like a tablet or capsule, or lozenges or troche. Whatever the pharmacy can compound, but it is a compounded product. It is not available commercially, and it's typically used for chronic pain purposes. Again, we'll be talking about injections, and we'll be focusing on pain, especially in the palliative care setting. So pain and palliative care, very commonly encountered, obviously. 2/3 of patients with advanced metastatic or terminal cancer patient population do experience pain. And moderate to severe pain is experienced in more than 1/3 of patients with cancer. And as palliative care providers are here, as you know, most of these patients can be managed with opioids, but there are a handful of patients who really just cannot have a good relief from the opioids by itself. So refractory cancer pain can happen about 10 to 30% of the population. And pain can limit function, and it causes a lot of distress to the patient, to the family, and definitely decreases the quality of life. So I try to look for randomized controlled trials in the setting of inpatient palliative care and the use of IV or sub-Q infusion. And there were only 3 that are randomized, placebo-controlled. And first one is Mackenzie and colleague looked at 10 patients who had with patients who had pain refractory morphine, but they didn't really define what that morphine amount was. But looking at the 10 patients, it ranged from 90 to 300 milligrams of morphine. And they provided bolus doses of ketamine, 0.25 mg/kg or 0.5 mg/kg, given over 30 minutes. And what they found was 0.5 mg/kg had better anesthesia, but more side effects, particularly with hallucination. Salas and colleague in 2012 did a study with 20 patients with cancer pain, with pain intensity at least 4 after morphine infusion over 24 hours. They didn't really specify the dose again here, and some of these patients didn't have opioid at baseline. And they provided ketamine dose at 0.5 mg/kg per day, and then increased to 1 mg/kg per day if the pain is still there. And they found no difference. The largest study I found was Hardy and colleague in 2012 with 185 patients, and patient with cancer pain with pain intensity up to 3, despite opioid and co-analgesic. Median opioid use was about 300 to 410 milligram oral morphine equivalents. And they provided sub-Q ketamine infusion, 100 milligram per day, increased up to 500 milligram per day. They saw no difference in pain control, but more adverse effects. But thinking about these 3 trials, though, 2 of them were pretty small, study with relatively low doses used. 0.5 mg/kg, thinking about 70 kilo patient on average, that's only 35 milligrams per day, compared to what the Hardy and colleagues use in much greater doses. But the Hardy and colleague study included patients with cancer pain with pain intensity 3 or greater. Is that really severe pain? Pain intensity is really subjective, so we can't really tell. And 3 sounds like a fairly low number in general. So was there really, better benefit of providing ketamine versus placebo in such a low pain intensity? I'm not really sure. But now looking at more recent studies, I found a couple of retrospective studies. Mackenzie and colleague looked at 44 patients with patients averaging about 437 milligram or morphine equivalents, provided ketamine infusion of 100 milligram per day for 48 hours. Again, this is retrospective, so that's an average that they gave. And midazolam 15 milligram per day was given for each of these patients. And found the pain reduction from pretty nice numbers, 7.8 down to 2.8. And none of the patients stopped ketamine because of psychomimetic effects. Chang and colleague in 2020 looked at 70 patients with pretty nice large morphine equivalents, dose of 300 milligrams per day. Provided ketamine sub-Q infusion. Their protocol starts at 50 to 200 milligrams per day, and then it titrated up to 400 milligrams per day as tolerated. What they found was pain did reduce from 7 down to 4, and 33 out of 70 had more than 50% pain reduction. Now, compared to the previous randomized control trials, these studies used higher doses and larger sample size compared to the 10 patient and 20 patient studies, and higher baseline pain score, about 7 with these 2 studies. So I think use of ketamine in that situation is probably useful in using these type of higher doses. So as you saw, these studies show variable results. So thinking about who should we give ketamine to? Definitely not a first line, not or routine use to provide ketamine. But I would suggest it's used as an adjuvant agent in patients with uncontrolled severe pain despite opioid escalation. Now, based on studies, sounds like more than 300 milligram morphine or morphine equivalents would be a nice candidate, but I would imagine even higher a more favorable patient population would probably benefit from it. Or patients who aren't able to tolerate further opioid escalation because of sedation or neurotoxicity, myoclonus coming in from the opioids probably be a good candidate. And also thinking about allodynia, hyperalgesia, those pain situations where NMDA is upregulated. And I would use precaution in patients with cardiovascular or psychiatric history, and I'll be talking about that more in detail later. So we decided to use ketamine. So what dose should I use? The studies that we looked at used about 100 to 500 milligrams per day. Divide that by 24 hours, that's about 4 to 20 milligrams per hour. So, sorry about that. And UW medicine dose ranges is between 8 to 15 milligrams per hour. And starting dose, I would probably start somewhere around 8 or 10 milligrams per hour as a starting dose. And I would titrate to response. And how frequent should we titrate it up? Probably every 8 to 24 hours. The frequency of titration is not really clear in the literature, but thinking about the previous slide with half-life, about 2 to 3 hours, thinking about that, probably every 8 hours is appropriate in some of the patients. But typically we do every 24-hour dose titration. As you saw in the studies, they provide per day each time. And at UW, we maxed the infusion to 15 milligrams per hour. And if you look at other institution or some literature, they might say milligram per kilo per hour or microgram per kilo per minute kind of dosing. Whether should you do weight-based dosing or not is really not so clear in the literature. So we decided to do just milligram per hour. And we've been talking about sub-anesthetic doses. And just as a reference, looking at anesthesia dosing, it's about 1 milligram per kilo per hour. Sedation use, it can be higher, even higher for status epilepticus. But looking at sub-anesthetic dosing, it is much lower. So that's what we use for pain management, even in palliative care setting. What if your patient has a renal or liver impairment? Well, like I said, ketamine does get metabolized by the liver and it's excreted renally, but the concern seems to be a lot less in sub-anesthetic lower doses. So there's really no specific dose adjustments recommended in the literature or in the packages or anything like that. So I would use precaution in patients with kidney or liver impairment. Maybe potentially start the dose at the lower end, maybe 8 milligrams per hour, and not titrate the dose as often as every 8 hours. Maybe do every day or even longer if needed, depending on the response to the patient. Well, we start ketamine on top of opioids. So what do we do with the opioid? So you know, ketamine is a sedating medication as well as opioid is a sedating medication. So definitely monitor for over-sedation, especially if that sedation does not align with the goals of care for the patient. And there may be some potential for a decrease in opioid need once you start ketamine. So I would try to avoid opioid escalation at the beginning. Just allow the ketamine to start working to see what the patient response is like. And if ketamine is optimized and pain is still not controlled, then I would then consider opioid increase if the patient can tolerate it. But at this point, you know, probably consider stopping ketamine because it's probably not doing much for your patient. Let's talk about side effects. The literature reported nausea, vomiting, psychomimetic effects, headache, fatigue, and sedation to be most commonly reported. But there are a variety of different side effects and other precautions that are listed out in the literature. And then there's the ketamine guideline for chronic pain use that was published in 2018, talked a lot about these different side effect profiles. So let's talk about each of these. So cardiovascular effects, ketamine is known to cause catecholamine surge and increase blood pressure or heart rate and also cardiac output. Why does that matter? It can increase myocardial oxygen demand, and in patients with high-risk cardiovascular disease, like coronary artery disease, unstable angina, uncontrolled hypertension, or heart failure patients, I'd be really cautious about it, but it's not really contraindication to provide ketamine in this population. And again, we're in a palliative care setting, so think about goals of care. Should we monitor blood pressure? Should we monitor heart rate? I think that really depends on the goal for your patient. But if you happen to be monitoring these vitals and see that they're raised, I would look for other cause first. Could the patient be in pain that causes these blood pressure to go up? Is there another infection going on, or acute process going on, or is there a medication that's causing it? So I'm thinking about those, but if increased blood pressure is not really aligned with the goals of care for your patient, and I would probably try to reduce or stop ketamine and see how that works. Pulmonary effects. One of the good things about ketamine is that respiratory depression is very rare. And so it is considered fairly safe to use in our population. But what other people have talked about with ketamine use is it can cause bronchodilation and also secretions, saliva secretions because of circulating catecholamines. But respiratory functions are mostly preserved with the use of ketamine. Psychomimetic effects. It is pretty common. Reported to be about 3.5 to 7.4% incidence. But this data mostly comes from perioperative ketamine use. Postoperative stay, they could have these psychomimetic issues as well. But it seems to be dose related, but there's no real clear cutoff or when would you expect that risk to occur. Even at low doses, like we use for sub-anesthetic doses and analgesia, patients do experience these psychomimetic effects. And these things are like vivid dreams, hallucinations, visual disturbances, delirium, dysphoria, dissociative sensations. So how can we manage that? Well, first we think about goals of care again. Is the patient okay with having this, hallucination that is comfortable for them? Maybe they see a rainbow in the room and pretty comfortable with it, or are they uncomfortable because of these psychomimetic effects? In those uncomfortable cases, then reduce the dose or stop ketamine. And if that psychomimetic effect is so severe or there's no improvement by reducing or stopping ketamine, then I would consider a low dose benzodiazepine, such as lorazepam or midazolam, or providing clonidine can help based on that as well. Genital urinary effects is pretty rare. I have not seen, or my colleague also told me she hasn't seen urinary issues with providing ketamine, but this seems to be more with a chronic ketamine exposure, or mostly primarily in illicit users, but it is fairly rare, but it's been reported. Some people talk about it, so I just wanted to put that in your back of your mind. Hepatotoxicity can occur, seems to be dose-related and repeated exposure, so for a long time exposure to ketamine. Again, it depends on goals of care, whether you're checking labs for liver enzyme or not. But if you happen to be checking liver enzymes for your patient and happen to see hepatotoxicity because of prolonged exposure, definitely look for other cause, but try to stop ketamine and see if that comes back down. Nausea vomiting is really common. 2.8 to 6.5% is reported to have nausea vomiting. And how do we manage it? Provide antiemetics would be good. And for contraindications and precaution, I kind of touched on it a little bit, but there are only small amounts of real contraindication reported in the guidelines and in literature. Definitely hypersensitivity, allergic reaction, anaphylaxis, don't use it. But patients with active psychosis or schizophrenia, probably you don't want to use ketamine with. There's been reports of precipitating hallucination and causing a lot of distress by providing ketamine to these patients. I would use precaution in other conditions such as increasing blood pressure, like we talked about, delirium patient with elevated ocular pressure. Ketamine seems to have some theoretical increase in increase in ocular pressure. So patient with acute globe injury or glaucoma, just be careful. But it's not a contraindication, and it got deleted out for some reason. But elevated intracranial pressure is something people talk about a lot with ketamine. The clinical significance of it has not been shown. It seems to be not very significant, and it's commonly used in traumatic brain injury patients too. But be careful in those population patients with CNS mass or other abnormalities in the CNS. Just be careful. And again, hepatic or renal failure patient population too. So going back to our case, the 41-year-old woman with metastatic breast cancer. So despite escalation of hydromorphone PCA, the pain continues to be severe and uncontrolled, and it is how we could not tolerate opioid rotation, and further escalation of that hydromorphone caused oversedation and mild numbness. So should this patient receive ketamine? I think this patient is a good candidate for ketamine infusion because of uncontrolled pain despite escalation. So I would probably start ketamine IV infusion at 10 milligrams per hour. You could start at 8 milligrams per hour. There's nothing wrong with that. I chose 10 milligrams just because patients are relatively young, a 41-year-old, without any past medical history, including cardiovascular or psychiatric or renal or liver impairment. So I thought maybe 10 milligrams per hour would be appropriate for a patient. Well, let's say for the day, and around 11 p.m., you get a page from the nurse saying, hey, patient is having 9 out of 10 pain. Can I give additional bolus from PCA, or can we increase the PCA setting? Now, looking back, you know that patient cannot tolerate further increase in PCA. And when you looked at the medication administration record, it's been about 8 hours since you started the infusion. And you ask the nurse if patient is having any of those side effects we talked about, and the nurse says no. So what can we do in this case? I think we could increase ketamine to 12 milligrams per hour. And I think 2 milligrams per hour increment increases or titration or tapering would be appropriate. And it's been about 8 hours. Patient's young, a lot of past medical history. Half-life is 2 to 3 hours, so I think it would be okay time to try out increase in the dose. So let's say we increase it further up to the max 15 milligrams per hour. Pain's been improving nicely since the dose escalation, but now patient is reporting visual and auditory hallucinations. So in that case, what can we do? I would probably trial ketamine reduction to maybe 13 milligrams per hour and administer the as needed lorazepam if that aligns with the goals of care for your patient. Now, I kind of want to talk about ketamine protocols that are available at UW. And it is currently being used for pain management in acute pain service, and chronic pain service sometimes use ketamine for a patient population. So the protocols or the order set I'm going to be showing is in the setting of APS or a CPS population. So when we try to order ketamine, we find these order sets and order panels. We choose the anesthesia pain ketamine infusion for pain order set. And in that order set, zooming into the ketamine infusion itself, it has a nice little guide, not to exceed 15 milligrams per hour. It defaults to 8 milligrams per hour starting dose, and then you can see that there's no nursing titration. And further looking into what the order looks like, it looks simple. It defaults to 8 milligrams per hour. You can choose whatever you want. And then you can see that no nursing titration, and the provider should adjust the dose every time we want to increase the dose or I wrote out what's written in the nursing order in this order set. It asks the nurses to check vitals and monitor for respiratory effort, get the pain score, look at sedation, and they have to monitor a little bit often, frequently for the first couple of hours. And then after 8 hours, that frequency can be increased to every 4 hours. And if infusion rate was increased, then again, more monitoring should be done by the nurses. But again, this is in a setting of pain management, not in the palliative care setting. So obviously, if your patient doesn't really, qualify for vital monitoring because of goals of care, then this needs to be modified for that. Going further, nurses are asked to call pain service if there's hypertension, hypotension, tachycardia, or low respiratory rate. And the nurses would call the pain service if they see hallucinations, patient feeling dissociated, reports of unpleasant, disturbing dreams, or inadequate pain management. Then they'll page the pain service. So we can definitely modify this for palliative care population as well. Finally, just other miscellaneous administrative information. At UW, it can be administered on a non-ICU setting, and the nursing staff have been educated for the use of ketamine, and the nursing will not titrate the infusion rate, like I said. The IV solutions seem to be compatible with some of the common medication that we provide in palliative care setting, but definitely consult with the pharmacy if you have a question about the IV compatibility. We have a large database that we can use to provide a better information. So in summary, as you saw in the studies, and I looked at other institutions. Other institutions are starting to use ketamine in palliative care setting. I would use ketamine in patients with uncontrolled severe pain, despite opioid escalation, or patients who are not able to escalate because of intolerance. Starting dose would be probably about 8 to 10 milligrams per hour. Maybe consider lower dose for patients who have really low weight, like 30-some kilo patients probably want to be on the lower side of the dose. Kidney hepatic impairment patients probably consider lower dose. Now, probably titrate about by 2 milligrams per hour, and that can be modified based on clinical decision. And titration can happen every 8 to 24 hours. A maximum dose we use at UW is 15 milligrams per hour, and common side effects are nausea, vomiting, and psychosomatic effects. So that is all I had. These are the references I used. And this is the QR code for the evaluation of this presentation. After that, I'll open up for a question and answer. And after the question and answer, Jim, if you're on, if you could talk about the next steps, what we want to do, the surveys and different things. So if you could do that as well, that'd be great. And thank you very much. I'd like to open up for question.
Thank you so much, Satoru. I think Nosley posted a question in the chat, and she was asking, do you still have nursing monitor these vitals if the patient is on comfort care?
Good question. I think, like I said, if it does not align with goals of care, comfort care, if we already stopped, looking at vitals, I would check vitals for your patient with ketamine. I would look at sedation, and if the patient is, doesn't want to be sedated, if they want to be interacting with the family, that's something to be considered. But otherwise, usually no.
Yeah, I think the point is that we would still align. Sorry, this is Mackenzie, the other clinical pharmacist here. We would always take into account, the patient's goals of care in that regard.
And David, I see your hand up, so I'm gonna ask David to unmute.
Yeah, thank you for this great presentation. It's exciting to see the UW protocol, and I think it's empowering for many of us to be able to kind of normalize the use of ketamine in end-of-life care. I have kind of two sets of questions, and I don't want to dominate the Q&A, but I'm just going to ask one general category, and that is, first, kind of pharmacokinetic considerations and kind of pharmacologic considerations. There is a literature on what to do with the opioid, and I'm wondering about backing off on the opioid when you start ketamine. And the rationale would be that this NMDA receptor antagonism may be a part of the mechanism for opioid-induced hyperalgesia. And in the case that you presented, I'm wondering about opioid-induced hyperalgesia as part of the mechanism. And so when we put ketamine on board, wouldn't it make sense to back off on the opioid? And some of the literature suggests that decreasing by 50% might be reasonable, and then kind of see where you're at. So that's one part of this. And then the next brief question is how long to continue ketamine. It seems like the end game for how long to continue is a little challenging to know. But what I've seen is a few days typically, but then what? So I'll stop talking and give you a chance to respond.
Go ahead, Sat.
As far as opioid reduction, thank you for bringing that up. Definitely, that is something talked about a lot in the literature with NMDA and involvement in opioid-induced hyperalgesia and things like that. I would say I would look at patient response and what the setting is too. And I think that is possible that the use of opioid would decrease in those populations truly going through opioid-induced hyperalgesia. And in the setting of probably use of PCA, I think that would allow the patient to control that amount. They'll be able to, they probably wouldn't press as much at that moment, and we can reassess how much patient required while we started the ketamine. And in terms of dose escalation, or not, I think I definitely don't dose escalate in opioid. I would really try to gather data how this ketamine is working for the patient. Sometimes they don't really work for the patient at all. So I think that's something to consider. One of the study did talk about it, providing ketamine did have an advantage of assisting in opioid rotation. But some of the literature, some of the clinicians do talk about using ketamine just for assisting opioid rotation. That's been talked about as well. And your second question, the duration, how long should we give this medication? The studies that we looked at, that I presented, was only 3 to 5 day course. So I think based on the evidence, I would suggest to try to limit somewhere in that area, 3 to 5 days. However, we also have to think about how effective that was and what the patient's goal was. Is the patient still comfortable with it? Feeling comfortable by receiving ketamine? Is the patient going through side effects from the ketamine? I think really depends on the patient's response, whether you're beyond 5 days or not. Mackenzie, if you would provide some more insight, be good.
Yeah, I'll just briefly say I wouldn't preemptively decrease opioids while initiating ketamine. I'd rather, I think the best practice would be to wait to see the response. And in unpublished literature by Scripps Mercy in San Diego, they actually reviewed, the MED decrease and patient satisfaction and pain scores and comfort of patients when ketamine was added in refractory pain patients. And they did find that overall, MED was there was statistical significance with opioid reductions, which then allowed patients after several days of ketamine infusions, around 2.5 days, they were able to transition to an outpatient opioid regimen because of their decreases in opioid consumption, and were able to, leave the hospital, which I think is kind of, depending on the patient's goal, maybe what you were alluding to is like, and then what, right? Are we just anticipating these patients staying in the hospital forever? What is our goal here with the ketamine, unless they are, GIP hospice, and we're just trying to find a way to improve their comfort while they're there. So that's kind of, and that study only had, I think, like 30 patients in it, but it's still a relatively decent sample size considering the other literature that we have.
And Satoru and Mackenzie, there are a number of questions in the chat, so I might just try to pull our attention to some of those. And I think folks who are willing to raise their hand or unmute to keep doing that as well. I just want to get to some of these in the chat. So Linda has asked, have you ever used ketamine in palliative care setting for refractory depression? And if so, is there a protocol?
Me personally, I don't think we've used it for that indication yet. So we don't really have any protocol for that indication. But for sure, there's been a lot of talk about using ketamine for depression for sure.
And then Pamela Davies is asking suggestions for how to distinguish end-of-life delirium from the psychomimetic effects of ketamine. There are things that you use to distinguish between the two so you know what to treat.
I would just look at, timeline for, when those symptoms were happening, oftentimes with either vivid hallucinations or some sort of delirium-esque symptoms with ketamine. You'll likely see that immediately upon initiation. So within the first 8 hours or after 8 hours from dose increase. So I think that would be, as far as like a timeline, a way to tell if that was potentially related to the ketamine. Now, if you're already suspecting that a patient is having some sort of delirium or hallucinations or things like that prior to ketamine, I would say, weighing the risks and benefits of, is pain a contributing factor, or is, just getting this patient comfortable because they just look so uncomfortable, then maybe ketamine would be an option. But I would start ketamine on a lower end of the dosing range. So if you're using weight-based, 0.05 milligrams per kilogram or 0.1 milligram per kilogram, if you're using, just milligrams per hour, maybe starting at like 4 or 6 milligrams per hour and kind of slowly titrating up from there. A lot of other institutions, San Diego, University of Iowa, Scripps Mercy, things like that, they will already have lorazepam be a part of their order set for ketamine. And I think that's for better or for worse, since we know benzos can also make kind of delirium worse. But that is a strategy that is used to kind of treat these potential delirium or hallucination side effects.
And then I'm just going to do one more chat question and then head back to, I know Cliff has had his hand up and Jim has his hand up. So Ellen Lee asks, is intranasal ketamine in the outpatient setting effective in refractory and or adjunctive pain management? And would you have a dose for that or monitoring recommendations for that?
Yeah, very good question. I know there are literature that are looking at intranasal ketamine in that setting, but unfortunately, for the purpose of this presentation, I didn't really go into that, and I personally did not have any experience in using intranasal ketamine, even for pain or even for depression, unfortunately. Anybody else have used it before that we did so?
I think it's just, a really exciting new tool to add to our toolbox. So we're thinking about ways that we can use it in the palliative care setting. So it's exciting, and it's clear that there's a lot more that we need to kind of hear about and learn about with regard to ketamine. Particularly, I'm hearing a lot in the outpatient setting. I'm going to switch over to Cliff. Cliff, if you want to unmute and ask a question.
Thanks, Danny. I had one comment and then two quick questions. The comment related to what David was asking, I'll just pass along that, what the acute pain folks will say, at least at Harborview, as far as duration of dosing. I think they're fairly standard, something like 4 to 7 days or so, and then they'll usually stop if someone's not going back to surgery. But what I've heard them say is that they feel like the effects can be longer lasting than that 4 to 7 day infusion. I don't know if there's literature on that, but a couple of acute pain folks feel like anecdotally they've seen that whatever effect is done in 4 to 7 days may stick around for, I heard one of them say several weeks afterwards. And so maybe that's more of a strategy to try to help wean folks off of IV medications over there. And again, I don't know if that's evidence-based at all, but that I think was their anecdotal experience. And then two quick questions. One was just what the prescribing limitations are at all the hospitals. I know at certain places for acute pain, it's limited to anesthesia. I think VA is one of those, and I'm not sure if Palliative now has an ability to prescribe in at the U or at Harborview. And then B, the other question is why, just curious why the order set limits the dose to 15, which is really only like 0.2 mg per kg per hour, which is on the very low end spectrum, I think. I think and especially knowing that analgesic effects, you can get more analgesia at 0.3, 0.5, and we give safer doses, obviously, for other purposes. And, is there any clinician alteration to that order set that you can do either on the floor or in the ICU? And because I think, if it's for psychomimetic effects, I've heard also anecdotally or seen a couple reports that you can preclude or you can block the emergence of psychomimetic effects with concurrent alpha-2 agonism with dexmedetomidine on board or clonidine. So I'm not sure if that's why it's limited to only 0.2 mgs per kg per hour, but curious on that. Thank you.
Yeah, thank you for that. I also want to comment on the acute pain service using ketamine and then having that effect. There was a study in the I believe it was a spinal surgery patient population that looked at perioperative ketamine use and saw benefit that I don't remember how many weeks, but it was several weeks ahead that they saw continued benefit in patients who received ketamine. So I think that's what they're referring to. As far as those other questions about I think more cultural things too, but Mackenzie's been around a little bit longer, so she could probably speak to that better than I can.
Yes, regarding the dosing, this predates me, but it was essentially anesthesiologist. So I believe Dr. Terman was involved pretty heavily with deciding the dosing. And prior to ketamine being used on the floor, it was exclusively used for sedation and sedation only in the ICU. And they felt that to use it on the floor, they wanted to minimize the potential for providers to escalate the doses outside of what had been previously documented as like the lowest effective dose. So it is a major limitation of this protocol that's at UW, is the fact that it really is only scratching the surface of what maybe other institutions have as like even their starting dose as 0.2 milligrams per kilogram, with the ability to go up to 0.5. And that is just our maximum dose. It really comes from safety from the anesthesiology side, which I think is a great practice, but also we don't have a lot of literature to say that it would be there would be lots of negative consequences if we increase that dose.
Thank you. And then the other thing was just on the prescribing limitations and who can prescribe at the U in Harborview.
Yeah, so
I'll actually go ahead, and Mackenzie, go ahead.
Perfect. Thanks, Jim.
Yeah. Yeah, so I'm actually going to jump in there. Some comments and then a question for the group as well. I think just from a process perspective, this is for the UW, MC combined campuses and Harborview. My sense is some of our team members are currently using ketamine occasionally. Part of the purpose of this talk is to really socialize our group to it and then create probably a follow-up module. It'll likely be something you can do asynchronous, meaning watch it and once you do it. And if, so I'll back up, sorry. For our group, our providers, I wanted to send out a survey after this, including this video, and just ask people their comfort with wanting to explore this area. Given we are a group of providers and share patient care, I want us, the majority or a good number of us, to feel comfortable with the idea of adding ketamine to our toolkit. Assuming we get a good response to that, then we will create a module just with a little more details, ask that people complete it and show completion. And then upon that, as long as we have a good enough group doing it, our hope is to add this into our practice. So to your question, Cliff, in theory, everyone and physicians and APPs in our group should be able to write and prescribe this. As part of the process, we would hope to create protocols that essentially mirror the pain ones, but modify them slightly. For Nosley's question around comfort care patients, what do we do in those situations? Our current palliative care PCAs have a mode for comfort care and non-comfort care patients. And so I just want to acknowledge that we may have patients that are very end of life and we are using this in to optimize comfort. And we may have other patients that we're treating for upstream pain and see this as a value added. And so to that end, a little more process to come out of this before I would hope that our group would regularly begin doing this, just because I want to make sure as we cover each other, we all have a level of comfort with this tool. I think with that said, I'm sorry for the 2-year-old in the background. I was curious if that and Mackenzie, when you or the pain service is talking about starting this with a patient or their family, what kind of sort of introduction do you give to it? Do you talk at all about sort of possible hallucinations? Is there anything that was good to think about from a patient context around, I want to try this for you all, here are some things you should know about it? And last thing I'll say is thank you so much for doing this talk. I think you both did an amazing job and I really appreciate it. I'll stop there.
Thank you for the comment, Jim. Yeah, good point about talking. What can we talk to the patient about? Definitely, thinking through all the effects, efficacy, and how do we, what's the expectation? So like, we use it to help with pain, potentially try to reduce the amount of opioid being provided, being administered, and also, talk about how we titrate things up, what's the expectation, and then what are the side effects, and that can be there, and how can we manage that if that becomes more discomforting for the patient. So those are the major points I would definitely talk about with the patient.
And I know we have about 4 minutes left, and there's a couple questions that I wanted to get to in the chat as well, since we do have Sat and Mackenzie here with us. So the 2 questions, I'll just ask them in sequence so that you can answer them. The first one comes from Caroline, and she's asking, studies are one thing, but I'm wondering what your experience is at UW and if it's been effective. And then Dr. Curtis is asking, do you have experience using ketamine for opioid withdrawal?
I'd say for using UW, I say mixed. So just like literature was showing mixed results, I say UW experience too. I think it's fairly mixture of results. And also some patients have those side effects, psychomimetic side effects that can tolerate it as well. Experience using ketamine for opioid withdrawal, me personally, no. I've used methadone or buprenorphine in opioid use disorder population, but not really anything else. Mackenzie, if you have any other comments on that, too.
And I think for the opioid withdrawal, we would just use our standard kind of treatments that we have, treating their symptoms. But we don't have any sort of policy or protocol, or I've never seen it be used to actually treat opioid withdrawal when we are tapering folks.
Yeah. Although ketamine has opioid receptor activity, the affinity of that is actually very low compared to NMDA. I believe it's like 1/10 or 1/20 of the affinity to NMDA. So it's actually fairly low for the opioid receptor.
Okay, well, I again just want to thank you both for this really fantastic presentation. Cliff is putting one last comment in the chat, and he's citing a trial suggesting you can mitigate psychomimetic effects with clonidine on board. Don't know if either one of you wanted to comment on that before we break.
I think that would be like the same sort of mindset. When I don't know who was bringing up using Precedex concurrently with a ketamine infusion. It's certainly something that could be utilized if you're just thinking like from a mechanism of action and looking at the pathophys of how things are developing. I personally have just never utilized that. Not to say that it's not something that could be potentially used.
Thank you, Mackenzie. And thank you again to both Sat and Mackenzie, because this was really fantastic. And I think it generated actually a lot of interest and excitement amongst all of us, because we can see, the potential. And if we learn more and are interested, again, please fill out the survey that's coming your way from Jim. And we'll see if this is something that we all want to try out and learn more about in the UW Medicine group. But thank you to everyone for joining us. And again, thank you to Sat and Mackenzie for a really fantastic presentation.
Thank you for the opportunity. Thank you so much.